Good afternoon, everyone, and welcome to the Board of Pharmacy's webinar today. It's our 2024 Compliance Update Question and Answer session. I'm Tom Glinsky, Chief Inspector with the Board of Pharmacy. With me today, I have Andy Miller, and she's an inspector on the western side, covers parts of Kansas City, Northwest Missouri, and Central Missouri. And then I have Inspector Lisa Everett with me. Today, she is in the St. Louis and Northeast Missouri areas. If you haven't been on our webinars before, you are in muted and listen only mode. If you're on a browser and have any on a computer, if you have any audio issues, you can on the GoToWebinar toolbar switch to a phone call and dial in. This webinar has been approved for 1 hour of CE. You must be entered on GoToWebinar under your own username to earn CE. You cannot share a user. If you're listening only by phone and not logged in, you will not get CE. I will go over more CE instructions at the end of the webinar. The board does not report to the CPE monitor, so make sure you save your certificates. And do not assume another state board will accept this. You should always check in advance to make sure they will accept CE approved by another board. If you'd like handouts today, there's various options to get that. You can go to the board's website. On the home page, go up to Upcoming Events tab, then choose, there's a link there that will take you to the webinar handouts link there, and you can print them there. Or if you're on, you can go to the GoToWebinar. If you're using a web browser to connect today, it's on your toolbar down at the bottom. You'll see a little tab saying handouts. If you click that, you will see a PDF of the handouts. If you're on the mobile app, you have to click the little more icon and then click materials, and then you will see the PDF of the handouts show up. We do record our webinars and post them on our website. We will have an extended question and answer session today. We did ask people to send questions in advance, and we'll take those first. But you do have a question during the webinar, feel free to do it. If you're on the browser, you go to the GoToWebinar toolbar, and there's a section where you can tab for questions. You can enter your question there and hit send. If you're on the mobile app, up on the top right, there's a little box with the question mark in it. You can click that. So now we'll get started with the webinar. We have it broken down into 3 sections today. I'm going to give you an update about pharmacist administration. Then we're going to have a conversation with Lisa and Andy, and then we'll go into our question and answer session. So we'll move into the administration update. So pharmacists have the authority to administer coming from 3 different sources. So they can administer vaccines by independent authority. They can administer vaccines with a physician with the protocol, and then they can also do vaccines and drugs by a medical prescription order. I'm going to talk about each one of those types individually, and we'll start off with independent authority. So pharmacists have independent authority to order and administer vaccines. They can do any vaccines that were approved or authorized by the FDA before January 1st, 2023, except for these 14 that are listed here. So those are not allowed to be given under independent authority. So this clause in the statute about after January 1, 2023. So that means any vaccine, new vaccines approved after that, you cannot give under independent authority. You can do it under a medical prescription order. We'll talk more about that. We get asked a lot, how can that get changed so we can do it? It will take a legislative change in order to get new vaccines added. Actually, in the 2024 legislative session, there was a bill introduced that would have changed the date. So it would include those that were in 2024. That bill did not really move very far, so that didn't get done this session. We get questions about reformulations and updated vaccines. An example is the yearly influenza reformulation. The rule 6.050 has a clause in there saying that pharmacists may administer reformulated and updated vaccines that were approved as long as the original one was approved prior to January 1, 2023. Any update or reformulation after that would be allowed. But we've been getting some new vaccines did come out in 2024. The Prembraya, which is a meningococcal vaccine, and the Capvaxive, which is a pneumococcal vaccine. They're kind of just new versions of some existing ones. The board did review these two vaccines and issued the following statement: that absent further statutory direction, that these two vaccines would be considered reformulations, and pharmacists may order and administer them under the statute and the rule. However, we always advise you to check with legal counsel to ensure compliance. So for individual authority, a pharmacist must administer vaccine in accordance both with CDC treatment guidelines and the manufacturer guidelines. And if there's a difference between those, CDC guidelines would prevail. The age limit for individual authority is age 7 unless CDC has a higher recommendation. You are required to conduct patient screening. The rule says based on general, we don't have any specific screening questions or how you do it, but it's supposed to be based on generally accepted guidelines to make sure the vaccine is appropriate for the patient, and you must document your screening. It also has a requirement that you refer patients if there's any contraindication or any other thing that you felt appropriate for referral out to a healthcare provider. So independent authority, because you can order vaccines, there is a new requirement that if a pharmacist orders a vaccine, you have to have these 6 items here. However, you will see a lot of these are the same thing that would be on a vaccine administration record. So those records, they could be the same record. I will caution you that number 4 there, the identity of the ordering pharmacist, should there be a separation of who's ordering and who's administering, then that record would need to have 2 pharmacist names on there. For prescriptions created under independent authority, the pharmacist will always be the prescriber on those. For delegation, pharmacists can delegate to interns and qualified pharmacy technicians. We'll talk about both of those in just a minute. You are required to report to ShoMeVax or the primary care provider. Again, we'll talk more about that one. And then for adverse event reaction, you are required to submit to the VAERS program and notify the primary care provider if the patient provided one. For interns to be able to administer, they have to have a current provider level CPR or BLS certification. They must have completed a certificate program similar to what a pharmacist does. And they have to be working under direct supervision of a pharmacist when they're immunizing. Qualified pharmacy interns, their list is a little longer. What their requirements are, they have to have an active pharmacy technician certification. So that means they're certified by one of the 2 certification agencies currently out there today. They have to assist in the practice of pharmacy, either in our state or another state as a technician for at least 1 year. They too need a current provider level CPR or BLS certificate. And again, they have to do a certificate program covering similar requirements of what a pharmacist does. Qualified technicians have to undergo initial and annual documented competency assessment in administration. And they have to be supervised by a pharmacist who is physically present on site. And so that's a little bit higher level of supervision there. For reporting to Show Me Vax, statute requires all vaccines given by a pharmacist be reported to Show Me Vax unless the patient opts out. Statute also requires that the patient sign an attestation to either being included or opting out. The board does have a sample statement if you need one. It's on our board's website of language you can use, but it's not just an opt-out attestation. They're also attesting that they understand that their information will be reported to Show Me Vax. If the patient opts out, the pharmacist must notify the primary care provider of the immunization within 14 days. That's assuming that the patient has a primary care provider. We're now going to switch to administration by protocol. This is covered under the regulation 6.050. It talks about protocol requirements, very similar to what it was prior to pharmacists getting their own independent authority. The protocol now must cover patient screening, which most of them already did. The protocol has to be with a physician. It cannot be with a mid-level practitioner. Protocols have to be renewed annually. That means they have to be signed and dated by all the parties involved, the pharmacist and the physician. And for any prescription created under this method, the protocol physician will always be the prescriber on that prescription. Very similar limitation and requirements applied by protocol as with independent authority. You can only do the vaccines allowed that I previously mentioned. So you cannot do RSV vaccine or the other 14 that were listed or anything that came out after January 1 of 2023. You are allowed to do reformulated updated vaccines. It's the same patient age requirements. You have to, again, follow CDC and manufacturer guidelines, and you can delegate to an intern or a qualified pharmacy technician. Notifications are similar, but there is an additional one for adverse event reaction. You, in addition to VAERS and the primary care provider, the protocol physician has to be notified of any adverse event reaction. If the protocol requires it, you have to notify the protocol physician of each vaccine given. Now that used to be a mandated years ago. That rule was changed to give the physician the decision whether they wanted those notifications. But if your protocol says you need to do that, you must do that. And then again, similar Show Me Vax primary care notifications. I'm now going to move to administration by medical prescription order. This is where a pharmacist gets a prescription for the vaccine or the drug from a prescriber, and then that allows them to also administer it. That's covered under Rule 6.040. And this allows pharmacists to do both drugs and vaccines. So some of the drugs we see administered by pharmacists would be, we've seen B12, we've seen some testosterone, we've seen long-acting antipsychotic drugs. I think we've even seen some long-acting birth control too. So it's out there. Any drug can be administered if it's prescribed and you're trained for that. So this is the method that pharmacists, the only method right now that a pharmacist can do the RSV vaccine, any other future approved vaccines, and then the 14 vaccines listed I talked about earlier. So they all can be done under this method. For this method is a little different. You must follow CDC or the manufacturer guidelines. So there have been some times where those differed, and the other two methods you would always have to follow CDC guidelines. In this one, it's either or. And there is no minimum patient age for this method, except for vaccines. You must follow CDC or manufacturer guidelines. Again, delegation to interns and qualified technicians is the same. For notification, adverse reactions, in this case, you're notifying the prescriber of the prescription and then the VAERS program if it's a vaccine. And if it's a vaccine, you are required to report to Show Me Vax or notify the PCP of that. And then under this, pharmacists can administer by other routes than what they're originally trained. So normally they're trained for IM and sub-Q. Our rule now talks about you can get trained for other routes. You don't have to go through the program similar. You just have to get training by some healthcare provider who does those. They can train you and you document that. So there are other options, some other routes that we've had pharmacists inquire about. So just a reminder on notification of intents, there are two different ones. It depends on what method you're using. So if you're administering vaccines by either independent authority or by protocol, there is an NOI for that. And then there's an NOI for administration by prescription order. So you need to make sure you have both of those submitted. Now that we're doing RSV by medical prescription order, a lot of people had to file their NOIs for that because normally they were just doing it by protocol years ago. If you're a new licensee or never had an NOI, you have to go online and submit an initial one. And then all NOIs can be renewed at the time of your biennial pharmacist renewal. If you're renewing online, it gives you the option to click over and do that online. If you're renewing by paper, you cannot renew an NOI on a paper renewal. You can renew an MTS certificate on your paper renewal, but if you're renewing by paper, you must then go online and renew your NOI. And just a reminder for people that are administering by vaccine, when you renew your NOI, you are attesting that you have 2 hours of CE related to vaccines or to CDC guidelines. And that 2 hours can be part of your normal 30 hours that you have to do for your renewal. It's not additional. Just want to call your attention to some of the resources we have out there. We have on the website the 2023 practice guide. We are currently trying to finalize the 2024 version. We expect to have out soon. We also have an August 2023 supplement guide that's out there that talks about some of the things we talked about today. And then we did do a webinar last year that talked about, it's mainly about independent authority. So those are out there. And then we have 2 documents on the website. We have the immunization administration checklist and then a technician assessment check template. So the first one is this. It's a 2-sided brochure. One side is administration by vaccine. The other is administration by medical prescription order. And it basically just summarizes all the requirements broken down into different sections. It's a great guide if you want to just do a review to make sure you got everything covered. But again, it's just a summary. You do need to read the rule too. And then the flip side is by prescription order. And then the other document is we created a sample, what a qualified pharmacy technician assessment could look like. It has different sections. Here's an example of vaccine handling and preparation. It has different sections. You do not have to use this. We created it because some people just wanted some guidance on what they thought should be in there. So we created one. It's out there, but you do not have to use our version. But you need to have some kind of assessment and document those assessments when you do them. So just briefly, I'm going to go over some common questions we get about administration. Can a pharmacist administer outside of a pharmacy, including the patient's home? The answer is yes. That's allowed under 6.055. You must follow that rule if you're going off site like that. However, if you're using a physician protocol, that protocol must indicate that you're allowed to go outside of the pharmacy. You no longer have to list all the places you would go like you did years ago, but you do need to have, if you're doing it by protocol, a statement in there that allows a pharmacist to leave the pharmacy. Do interns and technicians sign the protocol? No. Do interns and technicians submit NOIs? No. People ask, can I do a virtual CPR recertification course? The answer is no, because our rule says it must include an in-person skills assessment. However, there are some combination programs that part of it's virtual, part of it's in person. Those would be acceptable, but a true virtual only one currently would not be. And then one last one, can a pharmacist delegate the administration to a nurse? The answer is no. A pharmacist can only delegate to an intern or qualified pharmacy technician. However, if you check out section M or the pharmacy practice guide, it gives some guidance on how other healthcare providers may be used, and it kind of gives some guidance on how you can document them using your inventory or how you might be able to use your pharmacy system to do billing for them. But in these scenarios, those other healthcare providers are using their own authority, however they get it. So a nurse might have a standing order, but that's they're not using the pharmacist's authority. Okay, so that concludes my presentation on an administration update. We're now going to have a conversation with Lisa and Andy. So welcome today, Lisa and Andy. And let's just see, since we're talking immunizations today, could both of you just give me some of the common issues you're seeing on the inspections you do in your territory?
All right, so one of the more common things I come across is for pharmacies that use immunization protocols that they can't find them. This is especially true if a pharmacy relies on float pharmacists a lot. I like to make sure everyone has signed that protocol, and there's not always a central place that they're keeping those records. Also, some pharmacies have started keeping electronic vaccine administration records, which is totally fine, but they don't know how to access them. So those are probably the biggest things I find. I also come across pharmacies that are just confused about whether they're using a protocol or not. Some pharmacists are using their own authority, others are using a protocol, and it just creates a bit of chaos there. For pharmacies that administer RSV vaccines, we're finding some very incomplete prescriptions from these doctors prescribing it. They'll just say RSV vaccine #1. It's not very helpful. It needs to have, route, dose, all the things that are required of script. And we're also finding for pharmacies that use technicians to do their administrations, they're not consistently documenting the administering technician as well as the supervising pharmacist on that record. So those are the big things I'm seeing.
Hi, going along with the technician administration thing, I have been finding a lot of missing records for technician credentials, things like their certification, CPR training, and their initial and annual assessment. So sometimes we have pharmacists have a hard time finding them. They may be kept in different spots. Sometimes technicians are keeping their own records. So it can be a little tricky to find all of that. And then another big thing I'm finding is not having the annual assessment. So a reminder that every year for a technician immunizing for their initial, and then annually you have to make sure that you do an assessment of their actual immunization technique.
Okay, so Andy, could you give any advice for how a pharmacist can stay compliant with immunization requirements?
Oh, sure. I definitely start with all those documents that you mentioned already in your presentation. It's really valuable resources, the practice guide, the supplement. Those are in plain language, a great review. Not a supplement for reading the law, but very good review. So I definitely point people in that direction. But also, check and see if your pharmacy or your company has immunization-related policies and procedures. They may have additional requirements that are different than ours. So definitely make sure to familiarize yourself with that. Make sure you know whether you're using a protocol or not. And then read through that protocol to see if there's any certain things you need to know about in there. Make sure that everybody, all the pharmacists administering, have signed and dated the most current protocol. And also just make sure that your qualifications are up to date. Have you completed the notification of intent? Is your CPR current? Have you done your CE? And then for the PIC or whoever's keeping track of the immunization records for a particular pharmacy, establish some sort of system to make sure that any technicians or interns requirements are complete and up to date, and that they're accessible as well.
Thanks, Andy. I'm going to flip it now to Lisa. What advice would you give to an immunizing technician to stay compliant?
Thanks, Tom. Along with Andy, I would recommend that technicians review the documents that they're performing immunizations under. So that could be your protocol or your policy and procedure. Make sure you know what your company requires. And then again, with credentials, make sure that all of your credentials are current. So you have to have technician certification, CPR training, and I believe that has to be done like every 2 years. Your initial training for providing immunizations, and then your initial and annual assessments. And then recommend setting up reminders for renewal and updating those so that you don't forget. And then a reminder for technicians that you can obtain the information from the patient, but the pharmacist has to be the one to review and approve the immunization. And also a reminder that your technicians are not allowed to counsel on immunizations. I think we've had some instances where we're finding technicians are providing counseling for the immunizations that they're providing. And then just a reminder that we have an additional resource, the technician immunization assessment checklist, to ensure that you might want to look over to ensure that you are compliant with everything.
And I'd like to add to that too, emergency medications. So make sure your EpiPens are handy, people know where they're at, and they're not expired.
Good one.
Okay, well, let's switch to investigations on immunizations. Have either of you conducted investigations related to immunizations? And if so, what did that investigation deal with?
So I've had a few. I think we all have investigations related to immunizations. One of the more prevalent one I've had recently is the immunization of RSV vaccine under a protocol instead of a prescription order. And then we've had some regarding the ages not being appropriate for the vaccine, or some issues of actually providing an immunization to a minor when the parent hadn't authorized the vaccine.
Yes, definitely seen those. Also, a lot of instances where the administering pharmacist has not signed the protocol, they've signed the wrong protocol. And a really interesting one lately where a patient came in for a vaccine and had supposedly received a particular vaccine in a different state, but the pharmacy only checked the Show Me Vax records and didn't inquire any further, and the patient apparently got the same vaccine twice. So patients don't always know what their immunization history is, so it's definitely worth asking, especially if they're new to you, if they've lived anywhere else, or what their vaccine history is to their knowledge.
And I kind of reviewed what some of the other inspectors have been investigated recently. We've had multiple complaints about information being submitted to Show Me Vax is incorrect. Either vaccines were not in there that had been given, vaccines that were in there that were not given, or the wrong vaccine was actually in there and wrong dates and stuff. So we've had complaints related to that. We've had a couple complaints, the public complaining about sanitation in the actual immunization area. It's unsanitary, trash, used Band-Aids on the floor, stuff like that. The public has actually filed complaints about the conditions. We've had cases where the wrong vaccine was given. The person came in for a flu shot. There was a mix-up and ended up getting a COVID shot. We've had complaint where the wrong version, an adult version, was given to a pediatric or vice versa of vaccines. And then going back, I think it was Lisa that said, make sure you understand your pharmacy's policies. We had a pharmacist that was terminated for not following the policy of self-administering flu shots. So those are some of the investigations that we've kind of seen across the state recently. Let's just talk about general inspections now. What are you both seeing as some of the common compliance issues in your territory?
So some of the things I'm seeing relate to the fairly new requirement to keep a record of temperatures wherever drugs are stored. So sometimes people don't realize that includes room temperature as well, and they're just doing the refrigerators or freezers. Sometimes they are doing all the recording that they're supposed to, but they're recording out of range temperatures and nobody seems to notice. And so it just is out of range for months on end. That's fairly common. C2s not being stored under lock. This is especially true for people who have really difficult to open safes or time delayed safes. They're just kind of clustering C2s near the pharmacist station or standing in an open safe, their legs propping it open or something while they're filling a few scripts. And also patient counseling. I'm seeing a lot of pharmacies not offer this to patients, especially patients picking up refill prescriptions. But I'm also coming across instances where the technicians are just freely answering patients' questions about their medication. And I guess they don't realize they've stepped into patient counseling, and the pharmacist, very busy pharmacy, they don't notice. But a surprising amount of patient counseling by text going on out there.
How about you, Lisa?
We're still seeing a lot of sanitation issues. So things like dirty sinks, really dusty shelves, and I'll expand that for shelves to even be like, I've seen pharmacies where the walls can have a lot of dust, and the vents in the ceiling can be covered with dust. The water dispensers are always a big issue. The reconstitute, sometimes when someone's reconstituting something, they put the tip of the reconstitute too far down in, and it gets that prescription drug on the actual tip of it, and then they're not cleaning that off. So there's a real potential for contamination there. And then things like loose tablets, capsules, papers, just cluttering the floors. Expired medications are always an issue. Sometimes, we find, I think I had an inspection recently where I filled a whole, one of those shopping baskets full of expired medications. Dispensing errors, we're regularly finding those. And then one of the things we routinely find is an issue with the PRN. So the doctor writes a pain medication or something to be taken as needed, and it's not listed on the prescription vial. It's not dispensed with that. And then one of our newer requirements to post a photo with your license, that's getting missed. And then also having name tags. Sometimes a company will have a name tag and it'll say what their role is in the company. So they might be the pharmacy manager or the front store manager. And I've had to tell people that when you are in the pharmacy, your tag has to indicate what your board license title is. So it should say either pharmacist or pharmacy technician or pharmacy intern. You can have it say manager, but you also have to have that additional information on there as well. So that's something I've seen a lot of.
Did either one of you mention the flavoring bottles being cracked?
Oh, no.
Okay. We're still seeing a lot of that where the flavoring bottles, the screw-on lids crack commonly. And then we also find them with just open, there's no syringe in the little opening there, and they're just left out open. See, what advice would you give a PIC or a staff float pharmacist for a smooth inspection?
Inspections are nerve-wracking. I know we've all been on the other side of it and had inspections ourselves. So my first recommendation is to be calm. We've been through it, and we can kind of walk you through the process. We have a lot of tools to help with that. But especially as a PIC, know where your records are kept. You don't have to fill out the inspection records locator, but it is beneficial for you and your staff if you're not there. And then along with that, know where your passwords are located. So there's a lot of passwords you might need, especially for that. The meth check has passwords, and for that one, I think it needs to be updated regularly. So make sure that you're keeping up with those and when things have to be updated, because you might have your password, but then it expired because you haven't logged in or changed your password every 3 months. And then that leads to us not being able to access those records.
And for PICs, if you're a brand new PIC at a pharmacy, look at the pharmacy's past inspections, check and see, what has the state of control been in the pharmacy in the past? Have they fixed the issues that were noted in the past? Also, the board does have a top 10 inspection issues document on their website, so you can see like what the most common violations are on inspections that we see in pharmacies, and check and see if your pharmacy is in compliance with those things. But the number one best resource is for any pharmacist is the board self-assessment. So on their website, there's this rather lengthy document that has a checklist of all the different things that we commonly look at on a standard retail inspection. And we don't want you to be surprised on inspection. So this one just goes through. You can split it up, don't have to do all the pages at once, but that way you know what we're looking for. You can verify your own compliance, make sure that the records we're looking for, that you know where they're at, other people know where they're at. It's just a really valuable tool. And I'm a little jealous it didn't exist when I was a pick.
Okay, so we're going to move on to our question and answer session. But before we do that, why don't each of us tell what a common question you get asked and the answer to it. So I will start off. The question is, can I transfer an initial controlled substance prescription? And the answer to that, it depends on what type of prescription it is. And I want to say this first. It's not the Board of Pharmacy that is preventing this. This is actual federal law I'm talking about here. So a written, faxed, or verbal prescription, initial prescription, controlled substance prescription cannot be transferred. E-prescribed prescriptions may be transferred if they're in compliance with 21 CFR 1306.08. And you need to look at that. It has different requirements. You can transfer C2 through 5s. They must stay in the electronic format. It's a one-time basis, and any refills must be transferred with the initial at the same time. Now, it's this must stay in electronic format that seems to be the hindrance of why it's not happening more today. This is something you need to check with your software provider to see if you have a system that would meet DEA's requirements. But it's not just your system. The pharmacy you're going to communicate with to transfer it to or from also needs to have a DEA compliance system. So again, this is really, you need to check with your software provider to see where you're at on if you're allowed to do it.
Right, so one that I come up with a lot for pharmacies that still compound is for a compounded prescription, what is a pharmacy supposed to do if they can't fit all the active ingredients that are in that compounded drug into the drug name field on a prescription label? Similarly, I get asked if abbreviations are okay or commonly known brand names. And the reason this comes up is the board rule requires that the actual name of every active or therapeutic ingredient contained within a compound be listed on the prescription container that you dispense to the patient. So this comes up a lot of times when pharmacies are using like clever or common formula names like Magic Mouthwash or Bum Balm, and that has absolutely no ingredients listed. When they're using abbreviations like Vanco or Lido or Difen, those are abbreviations. We probably can figure them out, but they're not the actual names of the ingredients, so that is not sufficient. Pharmacies will put Benadryl or Maalox on the label that a patient gets, but they used a generic to prepare the compound, so that doesn't work either. Or they'll use overly generic names like antacid, but you need to really specify the actual ingredient, like aluminum hydroxide, magnesium hydroxide, something like that. Some have simethicone in it, and those all need to be listed on the container. So when trying to comply with this requirement, pharmacies usually first try to squeeze them all into the drug name field of the RX label, but when that doesn't work, remember it's only the active or therapeutic ingredients needed. So there might be some ingredients you can like not list if they're not active or therapeutic. That might get you the space on that RX label that you need. Also, it doesn't actually need to be in the drug name field of the prescription label at all. You can use the empty space on the label, if there is any, to maybe type the ingredients into the SIG, but you do have to do that for every compounded prescription that you enter. Or you could handwrite the ingredients in the blank space of the label, though you have to remember to do this with every fill. Also, it doesn't even need to be on the actual prescription label. You can use auxiliary labels. Some pharmacy software systems can be set up to populate this automatically. So usually I point people directly to their software provider, explain the situation, and see what solutions their software provider can offer them. For pharmacies that only make 2 or 3 compounds, they can pre-print their own auxiliary labels using some address labels you get at an office store to list out your most common formulations and just keep them with the compound log for easy use. But whatever method you choose, definitely standardize the process as much as possible to ensure continued compliance with this.
I get a lot of questions about 90-day supplies for a C2 medication. So a common one is the doctor wrote a 90-day supply of a C2 medication for a patient who is traveling. Can I fill it? And so the BMDD regulations state that a 90-day supply of a C2 medication can be filled for a medical reason only. So travel or insurance or I'm going to college or I'm moving would not be an acceptable reason for dispensing a 90-day supply. The BMDD has provided guidance in the past as to what constitutes a medical reason, and it rests not only on the diagnosis, but the medical reason that the patient can have 90 days versus 30 days. And one of their keys is stable. So while someone may have chronic pain or attention deficit, if they aren't stable, if they need a lot of dosing adjustments or changing to their medication on their medication regimen, they shouldn't get a 90-day supply, whereas someone who is stable on their meds would be a candidate. This information needs to be documented on the prescription by the prescriber, or it can be added with proper confirmation from the prescriber and documentation in your prescription record.
Okay, so now we're going to start with the questions that were submitted in advance. But if you would like to ask a question live now, you can go on your web browser or your mobile app and submit the question to us. I will tell you, there will be some questions we will not be able to answer. So don't be alarmed if you send a question and you don't hear an answer to it. So let's see. We have someone asking, what is the Board of Pharmacy's positions on quotas, such as quotas, so how many vaccines have to be given a day or other things like that, that might affect how a pharmacist operates in a safe manner?
I can take that. The board doesn't have regulations that specifically address the use of quotas, but we do have a statute that says that pharmacies must be operated in a manner not to endanger public health or safety. There's also a regulation that states pharmacies are prohibited from introducing or enforcing any policies, procedures, systems, or practices that jeopardize, inhibit, or threaten patient safety or the safe provision of pharmacy services. And so we have a section in the practice guide, section E9, that you might want to consult for additional information on that one.
Okay, someone submitted a question about something they saw in another state board's newsletter. It was actually the Kansas July newsletter, if you're interested. And it was an article about that board was alerting their licensees about they were aware of some federal actions taken about pharmacies who were accepting e-prescriptions for C2s that were titled refill authorization or renewal authorization. So it appears that the prescriber, something on their end, they didn't send a new prescription, but they just clicked to refill it, and that came through totally as appearing to be a refill. Someone wanted to know what we know about that.
Unfortunately, we don't have a lot to provide you. The article seems to be talking about the federal DEA requirement regarding e-prescribing. We are not aware of any of the specific cases that the article references, and we would just suggest that you contact DEA for more guidance on this topic.
We got a question about can a technician go outside and administer a vaccine at the drive-through? and then they have a follow-up question. If not, if a pharmacist goes out, does the pharmacy have to shut down while they go out, or if there's only one pharmacist there at the time?
Okay, so without further board review, the pharmacist would have to be outside and supervise the technician. The board has not issued any guidance on preparing, compounding, or dispensing prescriptions that could occur in the pharmacy if the pharmacist leaves the building in order to provide an immunization. We're going to take this question to the board at a future meeting. In the meantime, you may want to consult an attorney if you need any legal advice.
Okay, we have this is a dual part questions wanting to know about single use of testosterone vials. Can they be reused? And then they also have questions related to the 90-day supply limit on controlled substances.
So the board hasn't issued any guidance on using single dose vials as multi-dose vials. We just recommend that pharmacists use their professional judgment when dispensing prescriptions. And since this quantity maximum issue is a B&D statute, we definitely recommend that you contact BNDD for guidance on how they interpret that. It's really best to reach them by email, bndd@health.mo.gov. So yeah, definitely reach out to them on that.
And so another one related to testosterone, they're basically asking, what are the options out there if a pharmacy, due to a small dose or something, is unable to dispense the quantity needed? So what other options are available for that patient in the pharmacy to get that for the patient?
Okay, so there are some options out there. It's probably more than this, but something that we've come across before is maybe the patient can talk to the prescriber and the prescriber can do some sort of office administration. Sometimes we have a few pharmacies that have decided to go ahead and do pharmacist administration with this, administering per medical prescription order. So pharmacy just handles the patient coming in, every week or 2 weeks or how often they need, and administers it to them. Or sometimes in really unique situations, the patient might best go to a sterile compounding class H pharmacy, and they can compound something for them that better meets their needs.
So here's a two-part question from an out-of-state pharmacy wanting to know where the board stands on USP 795. For those not familiar with that, that's the non-sterile compounding chapter. And then they have a follow-up on where does the board stand on flavoring as compounding.
Okay, so the board does have its own compounding rule. It's under 2.400, and they have not adopted USP 795. They will have to revise the rule in order to adopt it, and at this time, they're not currently working on it. And then the second part of the question about flavoring is, flavoring is not considered compounding under our current rule.
And this is another out-of-state question. Some states require pharmacists to report incidents like dispensing errors to the board. Does Missouri have that or considering such?
So in general, the board does not require the reporting of dispensing errors, but we do have some reporting required for issues that's related to compounding.
So someone's asking about using therapeutic interchange for dispensing to a long-term care facility. Is it legal in Missouri to have some kind of auto substitution set up with the prescriber?
Right, so currently Missouri statutes don't allow for the use of a formulary to conduct any long-term care therapeutic interchanges. Now, in the past, the board had proposed some legislation to create this. However, we did not get approval to file that. So that does not exist currently. There were some statute changes in 2023 that affected medication therapy services. So once those rules are revised to match the statute revisions, that could possibly be an avenue for therapeutic interchange to occur with some limitations. The board's currently working on that revision. However, we do have to do some joint rulemaking with the Board of Healing Arts on that. which always, any joint rulemaking is a little bit slower.
Someone's asking, can we immunize kids ages 3 and 5 and above using the Federal PrEP Act for flu and COVID vaccines?
So yeah, we can. The Federal PrEP Act does allow pharmacists to administer an order for kids down to age 3 for COVID, influenza, and other childhood vaccines. You have to comply with the PrEP Act requirements, and a protocol can't be used for this. As of right now, the PrEP Act is set to expire on December 31st of this year, and we're still waiting to find out if it will be renewed.
Someone's asking, when we're talking about ordering vaccines, do we consider that to be prescriptive authority?
So the statute uses the word order, but we do consider it to be prescriptive authority for the vaccine that's allowed, or vaccines that are allowed.
We have someone asking about DSCSA requirements, especially for smaller pharmacies. I have a couple different questions, but in general, can one of you give us an answer just on DSCSA in general?
Sure. So DSCSA is a federal law, and unfortunately, we cannot provide any guidance on it. However, you might check the website dscsa.pharmacy for guidance. It's a website that's been created specifically for dispensers.
Okay, we'll start taking some of the live questions now. Hold on, it'll take us just a little bit. Okay, so if someone's asking about hazardous drugs, are you required to separate them from your normal inventory?
The board does not have any current requirements to separate hazardous drugs from your inventory.
Someone's asking, is there an expiration date? I assume they're meaning on filling a C2 prescription. Is there a limit on how long it's good for?
Okay, so this one's a little more complicated than it used to be. C2 prescriptions expire 6 months after the day they're written. However, if you do a partial fill on a C2, the remaining dosage units on that C2 prescription expire within 30 days of the date that it was written, unless it's a hospice patient, and then it's within 60 days of the date that the prescription was written.
So someone's asking, what is there still a 72-hour time limit when dispensing the remainder of a C2 prescription?
Okay, so that one's a little tricky too. The requirements have changed. So if the pharmacy is unable to provide the full amount of the prescription at the time of dispensing, they would be required to have the balance in within 72 hours. There is a longer allowance if the patient or the physician requests a partial supply.
So someone's asking about what are the options for remote pharmacist verification dispensing of products. I assume they're asked, I'm going to answer this as you're talking about final verification of the product. We do allow under a rule for a pharmacist to be able to check it using an image. So they wouldn't have to be in the pharmacy to verify it using an image. They could be remote to do that. That rule is very specific, so you need to review that rule. Then there's also under Class R, where it's a technician running the pharmacy, all those prescriptions are verified remotely. What do you do if the patient does not have an existing primary care doctor? I assume they're talking about for administration.
Okay, so yeah, it's one of the required things to put down. If the patient provides a primary care doctor's name, then you need to record that. Some patients honestly don't have one, and so there's nothing to record.
So someone's asking, are there 3 NOIs now? No, there's still just 2. There's one that covers vaccine by independent authority and by protocol, and then there's one specifically for medical prescription order. We have someone, this is following up on Lisa's answer on the joint rulemaking. They want to know, is there a timeline on this? The board drafted the language. To be honest, I don't know if we've sent it over to Board of Healing Arts yet or not, but that will be the next step, is to send it over to them and then work jointly with them to finalize a rule. And then once that's in place, then pharmacists will be able to, some of the changes that were made to that statute is you will not need a order to start the MTS service for a patient, and then that will free up you to be able to use that on the MTS protocol on multiple patients of that physician. Someone's asking about, can you self-destroy controlled substances in the pharmacy by filling out the form DEA Form 41? The answer is yes. You need to read the board. That's a DEA requirement on how you can do that. Sorry, I have to refer you to that. Someone's asking for clarification on how long you have to fill the remainder of a C2 prescription. They're asking specifically about long-term care. So there is a difference for that one. I don't think whoever answered that one covered that. It is 60 days if you're partial filling a long-term care. It's 30 days if you're doing a patient or prescriber request. Someone wants to know, is there a benefit to having a protocol versus using independent authority? I don't know if I can really answer that. I can tell you, I believe the reason some people need to use the protocol is because they're not set up as a provider with the insurance that they're billing. So they need to set it up with a protocol, but I don't think the board can answer if there's any other benefits. So we're almost out of time now. So we're gonna have to stop the question and answer session. If you have questions, if you need answers to things, check the practice guide. As I said, a 2024 revision should be coming out soon. It is searchable. There's an index with links that you click something on the index, it'll take you to that section. If you also can do a find and search a document for a specific word. You can always email your inspector. You can email the board office, and you can also submit questions via the board website. And then here's 2 email addresses for controlled substance questions, BNDDs, and the bottom one there is DEAs. We will record today's webinar. It can take 15 days or more before we get it posted. Currently, our 2024, we only have one other one. If you're looking for the DEA webinar we did back in May, we were not allowed to record that one, so you will not find that one on our website. And for CE, if you want CE, you must complete the post survey. If you're using a browser, do not close your browser. Click close on the little window that opens up when after I say I'm closing it. Stay on your browser, and the survey questions will pop up. Answer them and click submit. It's my understanding if you're on the mobile app, those questions automatically pop up. If you do not get the questions, send an email to compliance@pr.mo.gov, and we will email you the questions, but you must Get the answers back to us by email within 24 hours. If you want CE, a reminder, we will email your certificates, can take up to 30 days. And again, save your certificates because we do not report to the CPE monitor. And so I want to thank Andy and Lisa for joining me today and helping out with the webinar. And I want to thank you all also for attending. I am now going to close the webinar.